Hello, my name is Kelly Earle, and today I will be discussing fine needle aspiration biopsy. I will be talking about what fine needle aspiration biopsy is, the history and evolution of this diagnostic study. I'll be discussing the patient presentation that would precipitate ordering this the diagnostic study fine needle aspiration biopsy. I will talk about the sensitivity and specificity of the biopsy as it relates to other types of biopsy. And then I will also be talking about some guidelines that a provider will want to observe before ordering this diagnostic study. So, what is fine needle aspiration biopsy? It is pretty much exactly what it sounds like. Fine needle aspiration biopsy is when a provider inserts a small needle, usually a 22 gauge, into a palpable mass or a mass that has been found via some other imaging, be it a ultrasound or mammogram, some other imaging, and this provider will insert this needle and aspirate some of the tissue back. The aspirate material will then be placed onto a slide where a pathologist will review it and see if the growth is a malignancy or a benign cyst or just a fluid-filled cyst. Oftentimes, providers will use an ultrasound probe to make sure that they are in the right location and that the aspirate material is indeed of the mass. And usually this study is done on breast lesions or lumps, any sort of thyroid growths, or lymph nodes. The history of fine needle aspiration biopsy is actually pretty interesting. Providers have been aspirating fluid off of their patients since as early as the 15th century. And it was with the industrialized production of the microscope as we know them now, that allowed providers to actually start looking at the fluid that they were aspirating off of their patients. Early on in the 1800s, the microscope was used in order to diagnose things such as pneumonia or benign cysts, and then tissue stains were invented in the early 1900s, and that really advanced the abilities of fine needle aspiration biopsies. In the 1930s, a group of researchers looked at more than 2,500 cases of fine needle aspiration biopsy and put forth some guidelines as far as what providers need to do, which really have set the foundation as for fine needle aspiration biopsy as we know it today. And those guidelines we'll talk about later in the presentation. Some of the biggest critiques of fine needle aspiration biopsy were that it could cause a phenomenon known as tumor seeding, which was a theory that if you nicked the tumor would would leak into the vessels and thus spread throughout the body. Another big critique was that there was no way, a lot of providers thought that there was no way you were getting enough tissue to properly diagnose any sort of malignancy. And so there was a lot of pushback, and it wasn't until the 1970s and lots of research and lots of literature that was produced between those 40 years, the 1930s and the 1970s, that fine needle aspiration biopsy started to be considered credible and safe and a really appropriate diagnostic study. So let's discuss patient presentation. Patient presentation is usually going to be any patient who has a palpable or non-palpable mass or lesion or nodule, if you will, on the thyroid, the breast, or any sort of lymph node. So as always, as we've been learning all semester, anytime you are thinking that you want to order a study, you need to take a thorough history and physical exam. So a couple of historical things that could precipitate a thyroid malignancy would be a history of rapid growth of a neck mass, childhood head and neck irradiation, total body irradiation for bone marrow transplantation, family history of thyroid cancer, or any thyroid cancer syndromes. Another guideline that needs to be followed with patients who you would want to order this on is an ultrasonography should always be conducted prior to a fine needle aspiration biopsy. So, breast cancer is the most frequently diagnosed cancer and leading cause of cancer death in women. Women who come in with will be getting a fine needle aspiration biopsy on their breast almost always have either found this lesion from a mammogram or from a breast self-exam or from a physical exam. And again, these masses could be palpated or an ultrasound may be used to help the provider find this lesion in order to successfully pull the correct tissue out of this out of those lesions specifically. And then with lymph nodes, a fine needle aspiration biopsy is just one of the safest ways to actually biopsy a lymph node. It's one of the least invasive and safest ways. So they just recommend that if you have a patient that has a known primary tumor and they have a surrounding lymph node that is abnormal, then you can that in of itself is enough for you to order this. Enough rationale for you to order this exam. So let's talk about the specificity and sensitivity. So the advantage of fine needle aspiration biopsy versus a core biopsy is that it is way less invasive. A lot of times this is an outpatient procedure. And patients do not need to stay in the hospital. They do not need to undergo surgery. They can go home. They have a very small incision. And so, but the downside of this is that it is a little bit less sensitive. So, one source says that false positives and false negatives diagnosis were seen in 1.7 and 7.1 respectively of biopsy proven specimens sampled by fine needle aspiration biopsy. And the corresponding values for core biopsy were 0 and 5.7% respectively. So core biopsy is definitely, it has no false positives and a few false negatives, whereas at 5.7% false negatives. Whereas in fine needle aspiration, you bump up to 7.1% of false negatives, and you're at 1.7% of false positives. And that was specifically for breast specimens. When fine needle aspiration biopsy was done for lymph nodes, the sensitivity and specificity of the diagnostic accuracy ranges from about 89 to 98%, and that's for the lymph nodes. And then in thyroid nodules, fine needle aspiration is most sensitive at detecting anaplastic, almost 100%, and papillary carcinomas. So for thyroid, it really is one of probably the best exam you can order to get that diagnosis. So let's talk about the recommendations and guidelines. One of the biggest recommendations and guidelines that came out of those studies in 1930s was that you had to know what you were doing. You have to be trained in this. This is not something that a family practice provider can just do. You have to be capable and knowledgeable about the specimen handling, and how the specimen needs to be prepared, and you really need to be educated and be realistic about your ability. One of the other guidelines is that that came out of that 1930s study that's still in practice today is always comparing the aspirated material with a normal, a quote-unquote normal pathology. So you can never just look at it and say, okay, that's benign or that's malignant. You always have to have a comparison slide of what a normal healthy tissue looks like. The other guideline is to always consult with a pathologist. Pathologists will be able to tell you what they think is appropriate and what is measurable, and really make sure that those expectations are realistic and safe for your patient. So what the considerations for what type of nodules should be considered for fine needle aspiration biopsy? So one of the sources that I found, which I thought was really interesting, said size is not a predictive factor. Guidelines recommended nodules greater than 1 centimeter with irregular margins, microcalcifications, taller than wide, and rim calcification should be considered. And then any nodule that has subcapsular locations adjacent to, so this is for thyroid, subcapsular locations adjacent to recurrent laryngeal nerve or trachea, extra thyroidal extension, extrusion through rim calcification associated with abnormal cervical lymph nodes. So those all, anytime that you have any of those findings, you should definitely be looking at fine needle aspiration biopsy. And then in patients with any sort of coagulation problems, any sort of bleeding issues, which often accompanies certain cancers, fine needle aspiration biopsy should definitely be considered over core biopsy, as the risks for bleeding and the like are so much less. So, in conclusion, we talked about the sensitivity and specificity, we talked about the patient presentation, we talked about some guidelines, and we talked about what fine needle aspiration biopsy is. I hope with this presentation that you feel more comfortable ordering it and feel more comfortable knowing about fine needle aspiration biopsy. If you have any questions, you can please email me at kelly.a.earl@gmail.com. Again, that is kelly.a.earl@gmail.com. And here are my references. Thank you so much.